I will like to present to you my at least 35-year-old work on craniovertebral junction. And Dr. Abida has already summarized to you my concept, and we have been working together for at least last 15 years together. And she has been a very strong worker on craniovertebral junction. You have seen her enthusiasm in her presentation. So I will present to you our modern understanding of craniovertebral junction surgery. There is no question in my mind, no doubt, that there is a complete revolution, complete change in the understanding of craniovertebral junction, not only just basilar invagination, in the entire concept, the treatment of rheumatoid arthritis, treatment of tuberculosis, treatment of basilar invagination, treatment of rotatory dislocation, treatment of lateral dislocation, and so many other things of craniovertebral junction, Chiari malformation, syringomalia. Everything has changed, complete revolution, and I am here to present to you this revolution of craniovertebral junction. Craniovertebral junction surgery is not easy. Don't get the impression that it is easy surgery. It is dangerous, it is difficult, it is complex. You can create very big disaster in this surgery. You can create complication of which to come out of those complications can be absolutely impossible. The patient can be crippled, the whole family can be crippled. On the other hand, if you know how to deal with the craniovertebral junction, if you can stabilize the craniovertebral junction properly, you can give instant new life to these unfortunate people. So there is no question that craniovertebral junction in general is a complex subject, but the treatment is quite dramatic, and treatment can be completely revolutionary for the patient and for the whole family. These are the beautiful bones of the craniovertebral junction, atlas and axis. You see, Atlantoaxial joint is the most mobile joint of the body. It is round and flat. You see, like no other joint, like sacroiliac joint and Atlantoaxial joint. The atlas transverse process, largest transverse process of the whole spine. C2 spinous process, largest spinous process of the whole spine. And more importantly, I am showing you the bone, this C1 facet. If you touch this C1 facet, there is no other bone in the body which is as strong as C1 facet. It is next to teeth. It is the hardest bone of the body. So we have to use this hard bone, the purchase of the screw in C1 facet in the C2 facet are remarkable, strong, and there is no question that screw fixation has now come to here to stay. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common instability of the whole spine. I must say very clearly, atlantoaxial instability is the most common instability of the whole spine, number one. Atlantoaxial instability is the most under-recognized. We don't know that we are not recognizing atlantoaxial instability. It is the most under-recognized and the most under-treated clinical entity in the subject of entire spine. Anatomy of this region is absolutely critical. We said in our paper a long time ago that vertebral artery has a dynamic relationship with the vertebra, with the bones. You turn the neck, the artery will go up on this side. You turn on the other side, the vertebral artery will go up on this side. So there is a dynamic phenomena, and the whole region is surrounded by huge veins which empty and open and close as the movements occur. So this dynamicity is very important in craniovertebral junction arteries. Facet is the center of movements. Facet is the fulcrum of atlantoaxial movements. Facetal stabilization is the treatment. If you can stabilize the facets, that is the final answer. If you stabilize remote from the facet, like you stabilize the lamina or the spinous process, that is a suboptimal form of stabilization. So we described this technique in the year 1987. You see, 87 was the first case we did. And then, of course, we have a huge number of cases over the period of time. My my answer to atlantoaxial instability is open the joint, remove the cartilage, put bone graft in the joint cavity. These three are the most important steps in this operation. If you do not know how to do these three steps, please do not touch craniovertebral junction. You cannot say it is difficult. If it is difficult, we have to learn. And if we have to learn, we can do. Unless we spend time in learning, we cannot do. It is difficult, but open the joint, remove the cartilage, introduce bone graft in the joint, and then do atlantoaxial fixation. That is the treatment. So this was the case that we did actually in 1987. And you see segmental fixation. If you ask me, craniovertebral junction instability is equal to atlantoaxial instability. Craniovertebral junction stabilization is equal to atlantoaxial stabilization. Occipito-atlantal joint is the most stable joint of the body. Occipito-atlantal instability is almost not known. Very rare cases of trauma where there is occipito-atlantal instability. Otherwise, this is the most mobile joint and the most unstable joint. I again repeat the three basic steps of this operation: open the joint, remove the cartilage, introduce the bone graft in the joint, and then do fixation. So this anatomical understanding, as we have heard earlier, is very critical. There is C2 ganglion just beyond the atlantoaxial joint. I described this sectioning of C2 ganglion in 1987. I am not saying I'm using C2 ganglion resection today in all cases, but some cases I do use. But this anatomical understanding completely opened the atlantoaxial joint for lateral mass fixation surgery. And in my estimation, it is a complete revolutionary. One step is entire change of gamut of atlantoaxial surgery. Of course, vertebral artery is the most critical issue in atlantoaxial joint surgery. Venous bleeding is the other issue. So these are the issues which we have to know. And in many cases, there are abnormal vertebral artery. In many cases, there is high atlantoaxial joint. But whether it is high, whether it is low, we have to do the operation of segmental atlantoaxial fixation. So this is a mobile dislocation, no controversy. Atlantoaxial fixation is the treatment, no controversy. Mobile flexion, you do, there is dislocation, extension, there is reduction, atlantoaxial fixation in reduced position. That is the answer. There is no controversy. For several years, this is not a new introduction. This is an old introduction. Only thing that has been introduced is this technique of lateral mass fixation. Earlier, these cases were fused by wire fixation and loops fixation and hooks fixation. But of course, those are now considered, at least by most of the people doing craniovertebral junction, as historical operation. We also discussed double insurance fixation, one screw in C1, one screw like Megal's fixation. So introduction of both these techniques, not in all cases, not in many cases, in some cases, we do this to reinforce, particularly in cases where there is a high riding vertebral artery. You see high riding vertebral artery, in that case, you go close to the vertebral artery and introduce your screw up. So this is one more patient where there is one screw in C1, one like Megal's technique. Lateral mass facetal fixation is the treatment of atlantoaxial instability. Vertebral artery, as it comes up, it goes medially into the atlantoaxial joint. This loop of the vertebral artery, of course, this is a very dramatic loop. It does not happen like this in most of the cases, but it can happen in some cases like you see here. And this medial loop of the vertebral artery close to atlantoaxial joint can completely demolish your surgery if you introduce the screw, and you can damage the vertebral artery. So that is the worry in all cases, how to handle the vertebral artery. How to expose and how to handle the vertebral artery is an issue which dominates the psyche of a surgeon who is going to operate on these areas. And vertebral arteries can be in various shapes, various sizes, various courses, and you have to know in a very three-dimensional perspective. This understanding is crucial for the surgery of this region. So as we have heard, we described this three-dimensional anatomy of three-dimensional models, which we use quite regularly now, particularly in complex cases. So now you see this beautiful atypical bone. This is, I call, a majestic bone with a crown of dents. There is a facet. This is superior facet. This is inferior facet. Superior facet is anterior, inferior facet is quite posterior. This alignment is unique for C2 vertebra. There is no other vertebra where superior facet is so much in front and inferior facet is so much behind. And also the vertebral artery is in relationship with the superior facet. It comes up and then it comes out of this foramen. So this relationship of vertebral artery in relation to the superior facet has to be very clearly understood before the operation. So this is the model which we made long time ago and published in my article. We made a kind of multiple quadrants, and we used the medial quadrants. And I just want to show you this smallish little video where you see this is the direction of the screw, medial and superior. That is very important. If you put straight down, you can kill the vertebral artery. Medial and superior is the best direction. Now we describe, some cases the vertebral artery is high in relationship to the superior facet. But you must remember the inferior facet is not in relationship with the vertebral artery. So when the vertebral artery is high, you can use the inferior facet for screw insertion. So caudally directed inferior facetal, or you can use transfacetal C2-3 screw or C2 screw in the inferior facet. That can be a good option in selected cases where the vertebral artery is quite high. Like in this case, there is high vertebral artery. You may not be able to introduce your screw in this, but you can use this inferior facet, and this can be used. Quite strong fixation can be possible. This is another case. You see there is dislocation and the whole lateral mass is quite destroyed, as you can see. So I have introduced the screw in the inferior facet of C2. The other thing that we recently discussed is that vertebral artery in the foramen can be mobilized. You see, this is the vertebral artery. You can drill on the C2 posterior aspect of the pedicle and mobilize the vertebral artery. So this is the vertebral artery in the C2 pedicle. You can actually mobilize. And I had discussed this in one article recently, where we mobilize the vertebral artery. So you see here, there is the vertebral artery foramen is quite high. And to introduce the screw in the C2 may be quite difficult. But what I do is open this, drill this posterior aspect. See, the bone is very thin. You drill and mobilize it inferiorly, and you can introduce this screw. This is believe me, this is not a difficult procedure, but this is quite worthwhile procedure, because when we land into a vertebral artery in this kind of a situation, we should have an option. Here is another case. You see the vertebral artery is quite high. The pedicle is quite thin. You cannot introduce your screw. So I mobilize the vertebral artery down, and I have introduced the screw in this fashion. Other thing that we described, laminar screws were first described by me in this article in 2004. Spinous process screws, spinolaminar screws, all these things were discussed in our article. So when the vertebral artery groove is high riding, and you cannot introduce your C2 screw, you can use the spinous process or spinolaminar screw. This is the drawing from, this is the picture from my article, which was published in 2004. There are some more, but now I don't use these laminar screws or spinous process screws, because I don't think it is necessary, because I have other options to play with. This was another case. Both sides, the vertebral artery were very high. And during that time, 20 years ago, I may not have been able to do that case, and I used this. But I must tell you, now I do not use this technique of laminar screws, and I 100% of times, no matter what, how the facets are, how high are the facets, 100% of time, I will do C1, C2 fixation. But I know it is difficult. I know that it is not easy. And I know even for me, it is not easy when I'm doing this operation for 35 years. So in that case, you might like to use occipital fixation if you are not able to do, but you must remember that use the strong, solid C1 facet for screw insertion, that is the best. We also introduced this intra-articular implants of the facets for the first time in the literature, initially in the Atlantoaxial joint, then of course in the subaxial joints, but these spacers have also become quite popular. These are patented by me in various institutions, including US. And this technique, I call it joint jamming technique. I must say that I don't use this technique very often. Introduction of bone is important in the articular cavity. Spacer is necessary in some selected cases. Like this case, you see the vertebral artery was very high. I could not introduce my screw, so I used this spacer as a technique of fixation. Other side, I used atlantoaxial fixation. The other very difficult technique is transcranial insertion of atlas screw. You see, sometimes the facet of atlas may be very, very high, and you may not be able to introduce your screw in this direction. So I do a small craniectomy in the occipital bone, and then work in this direction to get the facet and then introduce the screw. And of course, C1, C2 screw, if you are able to do, you give a brand new life to the person. You must remember, and if you fail in doing, you can have a person who may not be able to survive for long. And even if he survives, he can survive in a very crippling situation. So this is very high basilar invagination, chiari malformation. You see the facet of atlas is quite high. So I do a small little craniotomy here, and then I go the screw. Of course, opening of the joint is necessary, introduction of bone graft is necessary, and then C1, C2 fixation. This is another case. See, the facet of C1 is quite anterior. You cannot introduce your screw, but mobilize the facet, do a small little craniectomy here, and then introduce the screw in the facet of C1, and you do C1, C2 fixation. As I mentioned, you may not be aware that, but the occipital screws were first described by us in the year 1987. These screws, I was very frequently using these screws, and this construct of occipital C1, C2 screw was described by us in 1987, 33 years ago. And now, of course, I do not use occipital fixation, as I mentioned in this article, but I also tell you that C1 fixation screw direct insertion may not be possible by people, at least, who are not extremely experienced in this subject. You have to be extremely experienced to be able to introduce C1 screw in all these cases. And if you are not able to do, then of course occipital fixation is an option which can be used. So what I describe, some kind of dislocation, you see in extension, it is reduction, flexion, it goes. This is called vertical, mobile, and reducible. Vertical. So this was an unusual kind of atlantoaxial dislocation. We also describe lateral dislocation. You see in bifid atlas, the facets are laterally dislocated. You can see the whole alignment is different. And in trauma, you can have lateral dislocation of the facets when the ring of atlas is broken. So we had introduced this manual realignment, open the joint, realign the facets, and then do fixation. This is remarkable. If you can open the joint, you can realign the facets. We also describe lateral dislocation in cases with tuberculosis where there is destruction of the ring of atlas. Rotatory dislocation, nobody in the world knew how to treat rotatory dislocation. Open the joint, manipulate the facets on both sides, and manual reduction has completely revolutionized the treatment of rotatory dislocation. And you can reduce, and you can give new shape and new happiness on the faces of these unfortunate children who are having no symptom other than torticollis, and this can be reduced very effectively and beautifully. Other revolution in the field of craniovertebral junction, I know many of the people are young people in the audience, but many are senior and experienced people doing craniovertebral junction. There is no doubt, and if there is a doubt in anybody's mind, please remove that doubt. This article, which was published as cover page of Journal of Neurosurgery, completely revolutionized the field of craniovertebral junction. It said that there is nothing like irreducible dislocation. Open the joint, manually manipulate the facet and reduce. There is no question of, of irreducible dislocation. This article completely revolutionized the field of craniovertebral junction. This was no flexion extension, no change. So this was a transoral decompression was the treatment for such cases, but open the joint, reduce the dislocation, and realign the craniovertebral junction, realign the craniovertebral junction. Now we have got hundreds of cases like this where realignment is done. Basilar invagination, as Dr. Abida was discussing, is an entity which was never really understood. It was not even a surgical entity in 1970s. After 1970s, have been some treatment described here and there, but no concrete discussion has been there on this subject. In the year 1990, we discussed these two types of basilar invagination. In one, odontoid process goes up, in one, tonsil comes down. The most important issue in 1998 was that this was considered to be irreducible atlantoaxial dislocation. This was considered to be a fixed dislocation. So as the entity was fixed, the treatment was transoral decompression in this and foramen magnum decompression in this. This was the treatment, and we described this treatment. So there was no confusion in my mind. Decompression was the treatment in 1998. So we discussed that basilar invagination is nothing but atlantoaxial instability like facetal listhesis, like lumbosacral listhesis. Stabilization is the treatment in selected cases. Listhesis is the problem. Stabilization is the treatment. We discussed this, and we introduced a new classification in the year 2004 and divided basilar invagination into two groups. One is where the odontoid goes up. There is a clear evidence of instability. Group B, where the tonsil is coming down, there is no manifest or validated parameters are not showing any atlantoaxial instability. In the year 2004, I described that such patients need decompression. Such patients can be treated by craniovertebral junction realignment, complete revolution in the field of craniovertebral junction and in basilar invagination. You see, there is basilar invagination. These are cases done by me 20 years ago. This is another case where there is open the joint, distract the facet, introduce bone graft in the joint. Instability is the problem. Stabilization is the treatment. Instability is the issue. These are not fixed problems. These are not irreducible dislocation. These are hypermobile, pathological dislocation. You can reduce, and you can reduce basilar invagination. This was my first case where I tried this opening of joint, and you can see complete realignment. Transoral surgery is completely not necessary. There is no need for any decompression. So these cases, if there are some senior people in the audience, these cases were treated all over the world at that time by transoral decompression. You will be, I am even surprised that even in several countries today, transoral surgery and transnasal surgery are being done for these cases. I will say completely historic. If you don't want to understand, nobody in the world can help you. If you want to still do decompression, nobody in the world can help you. That is an entirely useless operation. This kind of huge basilar irreducible dislocation can be reduced. Now, another thing I want to tell you is if the reduction is not complete, it doesn't matter as long as you have done a solid fixation. Another thing which I want to discuss is a chronic atlantoaxial dislocation. Long-standing atlantoaxial dislocation, there are huge number of natural reparative games that happen. And as we have already heard earlier, short neck, torticollis, Klippel-Feil abnormality, platybasia, bone fusion, assimilation of atlas, C2-3 fusions, bifid arch of atlas, and a host of number of problems are secondary to one issue, and that issue is atlantoaxial instability. You stabilize the atlantoaxial joint, all the issues which are secondary musculoskeletal changes I think this article also, where I discuss a large number of patients, has been a complete revolution in the field of craniovertebral junction. You can have a long neck, you can have reversal of torticollis in the immediate postoperative phase. There is no need for any osteotomy. Cervical fusion is a protective phenomena. Clipple file abnormality is a protective phenomena. Assimilation of atlas is a protective phenomena. It results in a short neck, and it is a manifestation of long-term neck muscle spasm. And if you have a multi-segment bone fusion, even if there is no compression at the craniovertebral junction, if you see bifid arch of atlas, even when there is no compression at the craniovertebral junction, there is only one treatment which can give new life, complete new life to this patient. And this patient was a very important patient and a very powerful politician's daughter. And you can imagine this patient started breathing properly after surgery and got a new life. If you say there is no compression, I will do some other kind of treatment, you will completely destroy this patient. Do not destroy this patient. This patient needs atlantoaxial stabilization. These bone fusions are secondary to primary atlantoaxial instability. This article, I discussed 190 cases of os odontoideum, and I must tell you, this entity of os odontoideum is not understood in many countries. And many countries still people are doing transoral decompression and occipito-cervical fixation. Absolutely not a good operation. You have to, this is a manifestation of atlantoaxial dislocation, and you have to do atlantoaxial stabilization. In my article, we said that this odontoid process is broken by God to help against the compression of the bone of the cord and the dura by the movements. So we have multiple changes in the cord as a result of os odontoideum. What is required is atlantoaxial stabilization. Syringomyelia, there are musculoskeletal issues, there are neural issues. Syringomyelia is a neural problem related to atlantoaxial instability, is a protective phenomena. I published this article in 1996, and there is no question in my mind. These are revolution in the field of craniovertebral junction. People were doing shunts and tubes in the syringomyelia 100% of times. But these are secondary protective phenomena. When there is a syringomyelia, there is presence of atlantoaxial instability. You have to stabilize. I want to introduce another revolution in the field of craniovertebral junction, the issue of central or axial atlantoaxial instability. This concept has completely expanded the horizons of craniovertebral junction surgery. Just rapidly see these three slides. You see here the facet of atlas is dislocated anterior to the facet of axis. So there is increase in atlantodental space, and there is compression of the craniocervical cord, and there is listhesis, and you have to do stabilization. Now carefully see this. This kind of basilar invagination, the whole world will do foramen magnum decompression. There is no atlantodental interval disturbance. There is no neural compression. But carefully see this facet. This is dislocated behind. This is type 2 dislocation. There is no question. If you do decompression, that is a nonsense operation, according to me. I am using these strong words to give a strong message, to give a clear message that this does not need foramen magnum decompression. If you do decompression, that is a waste of time for the patient and for the surgeon. This patient needs atlantoaxial stabilization. Even when there is no atlantodental interval disturbance, even when there is no facetal abnormality, presence of basilar invagination, presence of Chiari formation, presence of syringomyelia are indicators of an unstable craniovertebral junction, and it merits the need for stabilization. If you have any confusion, please do not keep that confusion, because that confusion will harm your patients. Learn the technique of opening the joint. These are not easy to open. This kind of high facetal C1 is not easy to expose. But if it is not easy, then you make it easy by your hard work and dedication towards this subject. I have published several articles on this subject now over the years. Basilar invagination is always associated with instability. In massive basilar invagination, syringomyelia, Chiari malformation, look at the facets. when facetal abnormalities, there is no question you have to do fixation. Even when the facets are in alignment, you have to do fixation, because Chiari itself is a manifestation of unstable spine. This kind of huge basilar invagination, not easy to do, no question, but if you can do it, you can give new life. Craniovertebral junction operations are not easy. Chiari malformation, basilar invagination, facets are in alignment, no atlantodental interval disturbance, needs atlantoaxial stabilization. So basilar invagination, 100% of times, it needs stabilization. And we have published several cases over the years where there have been almost, I don't want to say almost zero complications in the entire series. I'm not saying zero, but there are almost zero. There are some, but you see, this was associated with 100% complications earlier. But if you know how to open the joint, you can give fantastic results. So transoral surgery, I have no hesitation to say that we completely demolished this surgery in the history of neurosurgery from the domain of books of neurosurgery. And I am saying today, and I'm saying to this EWNS group, WC group, that there is no question that foramen magnum surgery, decompression surgery, is an entirely unnecessary operation and is bound to be eventually turning out to be a historical operation. So basilar invagination, syringomalia, Chiari malformation are all secondary to one problem, and that problem is atlantoaxial instability. Atlantoaxial instability is the cause of Chiari malformation. Whether there is bone malformation, whether there is basilar invagination or not, they do not need all these kind of decompressions. They need stabilization. Syringomalia, Chiari malformation, no facetal abnormality, no atlantodental. You do fixation, you see the magic. You see the tremendous magic in the life of the patient and in the life of the family. You see the syringe disappears eventually in 100% of cases. If you have scan after 1 year, if you have scan after 3 months, you will see at least 20% patient syringomalia disappearing. But whether syringomalia disappears or not, 100% will improve in a fashion that you have not imagined in your treatment of syringomalia and Chiari by decompression. Fixation is the treatment, and syringomalia and Chiari are children of one entity. That entity is atlantoaxial instability. No problem of the facets, no problem of the instability. Chiari is no problem of tight posterior fossa. It is anteroposteriorly large, vertically reduced, and like the spinal canal, atlantoaxial fixation is the treatment. These kind of scans, preoperative and postoperative reduction, are a huge number in my department now. And those who are having confusion, please don't keep it. And if you have confusion, there is a very simple option that come and spend some time. Like 314 international fellows have come to my department. I have a list of all this. Even from Egypt, I have got several fellows, and many of you are sitting in the audience. I know it. And they know what is the treatment of Chiari, and they have no confusion. I will suggest, don't keep confusion. Come and I will show you several cases of syringomalia with reduction, and know whether there is reduction or not. Remarkable clinical improvement. Even when there is no bone malformation, the treatment remains atlantoaxial fixation. No bone malformation, but see the facets. See there is no problem in bones, but see the facet. Even when the facets are in normal alignment, they all indicate the need for atlantoaxial stabilization. And this, I am showing you just images, and then we have introduced several other nomenclatures. Idiopathic syrinx, nobody in the world still knows the treatment, but syrinx is one of the other children, one of the several children of atlantoaxial instability. You treat the father, the child will disappear into wilderness. Atlantoaxial instability is the father of basilar invagination. Atlantoaxial instability is the father of Chiari formation. Atlantoaxial instability is the father of Klippel file abnormality. It is the father of dorsolumbar scoliosis. It is the father of os odontoideum. Is father of syringomalia, and father of a number of musculoskeletal abnormalities in the cervical spine, in the dorsal cervical spine, and in the lumbar spine. Thank you very much. I have one video to show, but I will show later because I know I have taken too much time. And if you have time for me, I will show you this video at the end
See,
of the presentations of Dr. Sarath Chandra and Dr. Sushil Patkar. So thank you very much, my dear friends.
thank you, dear mentor and teacher, Professor Atul Gwel. It was a brilliant presentation, as we are accustomed to. You have learned us a lot and give us an honor to be with us today. Thank you, sir.
Thank you very much. Thank you. It is indeed my pleasure. And I send you my best wishes to your group. I know there are 8,000 people who responded to you for this invitation. And I know there are more than 5,000 members of your society. And I have no doubt that you will make the strongest group of neurosurgery in the world. And I send you and Dr. Sameh my best wishes. And I am sure we will be able to organize several webinars and seminars like this in the coming future. Thank you very much for making me part of it. Thank you.
Thank you, sir.